Hi, everyone, and welcome. I'm Mary Smith, a registered nurse and executive director of the Association of Regulated Nurses of Manitoba. And so glad that you've joined us tonight for this Talk Tuesday featuring public health nurses, Mari Lintott, Sylvia Camero-Taveras, and Tanya Horton, who will talk about the significant upstream work being done in the public health sector during this pandemic. But before we proceed, I would like to pause and acknowledge that the Association is proud to recognize all of the traditional territories upon which the nursing profession works. We acknowledge that we are in Treaty 1 territory and that the land on which we gather is the traditional territory of Anishinaabe, Cree, Oji-Cree Dakota, and Dene peoples and the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. All right, I'm now really pleased to introduce to you our facilitator for this evening, Melanie Gazelle. She's a registered psychiatric nurse, and she's going to get us talking. Thank you, Melanie.
Thank you, Mary. Well, it's great to be back here on Tuesday nights. I always look forward to our Tuesday evenings together. And today's going to be another great presentation. I'm really looking forward to it, to hear about the public health perspective. But before we get started, I can tell you a little bit about me. I am a registered psychiatric nurse, and I have a psychotherapy practice in Southern Manitoba, as well as a psychiatric emergency nurse for Southern Health Santé Sud. So we really just, first of all, want to thank the listeners in Zoom land who have been logging on every weekend joining us. And I also want to offer a special welcome to those of you who are new, who are also joining us this evening. It's just great to see that the numbers are rising and there's a lot of interest here on our Talk Tuesdays. So we really like to use this time to get together and to be supportive of one another. It's very challenging times as a nurse right now, and so we want to acknowledge that and validate the work that you're doing. We also talk about some of the positives and things that we're grateful for, like to listen to one another and have people share stories and ask questions in a safe environment. And then, of course, being kind to one another is always at the forefront. So just before we get started, I want to take you through the instructions for Zoom. You will see on the bottom of your toolbar there's a couple of different icons. And at first we start off in a webinar format where the presenters will be giving their speech, and then you can pose questions in the Q&A box during that time. Or if you'd like to use the chat box as well, you can certainly go ahead and use that. And once the presentation is complete, then I will be opening up the question and answer box, and we will be taking questions that way. I'll be reading them out, and then we can answer your questions. So really hoping to have an interactive discussion this evening. And yeah, really looking forward to the topic tonight. So just another quick piece before we get started. We do record our sessions, and that is because if people can't view the presentation on Tuesday evening, they have the option to do that later in the week at their own leisure, but we don't post the question and answer part. So that is kept confidential, as well as people who are registering for our evenings together. So I would like to pass it over now to our public health nurses, Mari, Sylvia, and Tanya, to give us their presentation.
Thank you.
Welcome to our presentation on the public health experience with the COVID-19 pandemic. I am Mari Lintott, and joined by my colleague, Sylvia Camero-Taveras, and Communicable Disease Coordinator, Tanya Horton. First, we will start with the definition of population public health. As you can see from the slide, we work with families, communities, and partners to promote health and prevent injury and illness. Our goal is to work with a variety of partners and communities, educating, advocating, and reducing health differences and improve the overall health of those whom we work with. This slide shows the various areas that public health is involved in. Example, communicable disease, healthy children and youth, immunizations, injury prevention, travel health. As you can see, public health has its hand in a number of different programs. On any given day, a public health nurse could be dealing with prenatal clients or managing a school immunization clinic or dealing with communicable disease investigation. Currently, public health across the country and the world is dealing with a pandemic. Here is the definition of pandemic from the World Health Organization. How do we control a pandemic? According to the World Health Organization, we look at these 5 points. Reduce human exposure to the virus, example, limit travel or have travel restrictions. Strengthen the early warning systems. Through surveillance and reporting worldwide, reporting of cases helps to determine the next steps or actions. Intensify rapid containment operations. Countries need to have a quick response to the emerging pandemic to stop the spread of the virus, trying to contain it. Build capacity to cope with the pandemic. This refers to having a response plan in place for further measures to stop the spread. Coordinate global science and research. Ensure that pandemic vaccines and antiviral drugs are rapidly and widely available shortly after the start of a pandemic, and that scientific understanding of the virus evolves quickly. We cannot emphasize enough the importance of rapid gathering of information to decrease transmission and spread of COVID-19 and the need for the centralized team. Winnipeg Regional Health Authority response to the COVID-19 pandemic was to have a centralized team who worked with Medical Officer of Health, Dr. Guni Fatoy. Here is a link to the CBC interview with Dr. Fatoy. Located at 490 Hargrave, starting with 6 public health nurses and then growing to 12 due to the increased number of positive cases in Winnipeg. The benefits of having this centralized team was the availability of resources such as the Medical Officer of Health, Communicable Disease Coordinators, and very much appreciated administration staff on site. We also were able to utilize travel health nurses who helped with workload. This was important to have all these resources readily available as the information was changing, often hourly, which allowed the team members to work as a team to get this time-sensitive work done. We had to be flexible and responsive to the timing of the positive lab reports and adjusted accordingly. We evolved from 5 days a week to 7-day-a-week coverage. We became very familiar with the Manitoba case investigation forms, and they quickly became our friends. We also valued the Public Health Interim Measures Guide developed by Shared Health to guide our practice during these investigations. WRHA developed its own quick reference guide based on the use of our case investigation forms. We first started with 6 public health nurses in this meeting room space, keeping in mind social distancing. But as the team grew, we then moved out into other areas to keep with that public health regulation. Once a lab-confirmed result was sent to Manitoba Health, it was then passed on to our team to start the case investigation interview, which was often quite lengthy as there are a lot of details needed to complete an investigation. We also assessed the client and educated them on next steps for their recovery. Once the case was completed, we then moved on to the contacts, which again could be lengthy depending on how many contacts each case had. There was education and assessment needed for each contact. The public health nurse would then explain to the case or contact, that active daily monitoring would be started, and based on exposure and symptoms, it often meant 14 days of self-isolation and temperature taking. There were times when this monitoring went beyond 14 days. Prior to the provincial call center being created to support the active daily monitoring, COVID-19 team public health nurses, community area public health nurses, as well as travel health nurses assisted with reassessment and support of clients who were on the monitoring. We then needed to document in IFIS, which is a web-based provincial health information system. Originally, we referred symptomatic individuals who fit testing criteria to urgent care or emergency, then to testing sites, and then assessment clinics. This was done to ease the impact on acute care system. As you can see, this was also changing rapidly based on need. First was setting up testing sites, then adding drive-through sites, then adding assessment sites. Today, we were able to open a new testing site at Thunderbird House to service our vulnerable and downtown populations. We have evolved to mobile response unit, which is making house calls for tests as well. Also, they've started an online website for lab results where the clients can go on computer and get their results. The general program of public health assisted with active daily monitoring by helping us locate clients who are unreachable by phone by doing doorstop visits. We did connect with occupational health for various settings based on cases and contacts. This was valuable relationship building as it built capacity within those settings to manage the cases. Benefit of centralizing the COVID team assisted linking cases for control and prevention. This can't be emphasized enough. Having the team centralized together allowed for quick identification of related cases, and that in turn allowed the medical officer of health to be aware of these critical situations and to promptly act on them. This is the Manitoba Health Case Information Investigation Form. This is 7 pages long, and the public health nurse could add pages if there were more exposures, transmission events, or contacts. We have had anywhere from no contacts to as many as 30 related to the same contact, very much like branches to a tree. We had 24 hours to complete this form and send it to Manitoba Health. Resources, as you can imagine, were constantly being reviewed, and we were looking at other resource links, such as Health Canada, that reflected on literacy level options. Nurses needed to assess their population and offer what resources were available. This is an example of the fact sheet Manitoba Health developed for self-isolation. Tracking tool for individual use when a case or contact was on active daily monitoring is what you see here. The public health nurses often emailed this as well as the self-isolation fact sheet to our clients. Screening tool. This is the tool that we use to assess general public to see if they met the eligibility criteria for testing. This tool was changed several times. For example, the earliest version began with travel history to Wuhan, China. This tool has changed, evolved to this current version over the last several months. Next up is Sylvia.
Hello, everyone. So I just wanted to share some statistics from across Canada. And I just wanted to explain that I had this slide from May 13th, and then I'm going to also show you from May 18th. So it updated. So on May 13th, we had across Canada 71,486 confirmed cases. Out of those 71,486, we had 34,496 that recovered, 5,209 deaths, and 31,111 people were tested per 1 million population. The next slide, as you can see, will be updated. So this was as of May 18th at 11 a.m. We now have a confirmed cases across Canada of 77,306, which is up 5,820. We have recovered 38,828, which is actually up 4,332 people. we have 5,805 deaths, which is up 596. For the people tested across Canada, we are up to 35,118 per 1 million tested, and that's up 4,000. So I just want to show you how vastly and how quickly cases are changing throughout Canada, and that's only in a matter of 5 days. So this is a map just showing across Canada where cases are worse, and unfortunately our neighbors, Ontario and Quebec, are having our worst cases. Here's a slide that shows the different provinces and territories and their cases that they do have, and focusing just on Manitoba. As of May 18th, we had 289 total cases in Manitoba. And if you can just see at the top there where it says majority of the deaths, which is 94% of the cases across Canada, 94% of the deaths were related to Quebec and Ontario, unfortunately. So looking at demographic distribution, 36% of the cases are age 60 and over. The next age group with higher proportion is age 40 to 59 of 32%. And then we have age 20 to 39 of 27%. Out of all the cases across Canada, 55% are female. And out of Canada, in total, we've tested 1.3 million, 20,063 to be exact. And I just wanted to point out Manitoba. So we did 34,042 tests. So out of 4,198 cases, of which the clinical presentation was reported, 561 cases were clinically and radiologically diagnosed with pneumonia. Among those 561 cases, 57% were aged greater than 60 and 40% were aged 60 to 79. Looking at the pre-existing conditions, our top three are cardiac, respiratory disease, and diabetes. The main symptoms that were reported across Canada were cough, headache, weakness, and fever. Clinical complications related to COVID were pneumonia, shortness of breath, and abnormal lung auscultation. And what I thought was interesting, just to point out how many cases were actually admitted to ICU. So out of 4,154 cases, we had a 16% reported to hospital. 931 were admitted to ICU, and 168 were hospitalized requiring medical ventilation. 74% of those cases reported one or more pre-existing condition. So just taking a closer look at Manitoba, and these stats were just made available today from the provincial report, which is now made public. And it just shows in Manitoba, each region, out of our 298 sorry, how many cases today? Well, it's 290 today. So it's 289 originally and 290 today. But this one is focused on 289. In Manitoba, we were able to conclude from our investigations the different symptoms that were reported. And that's what actually guided our questions for when we sent people in for testing. And as you can see, we have some loss of appetite, vomiting, runny nose, loss of taste and smell, and those were added later to our form. Based as of today, May 19th, public health officials advised that there were no new cases of COVID-19. We are at 290 today. One individual is currently hospitalized, and nobody is in intensive care. 26 active cases exist, and 257 individuals who are now recovered. The number of deaths due to COVID remain at 7 for Manitoba. In Manitoba, public health nurses practice in a generalized program. It involves several aspects of public health that Vori had discussed earlier in the slideshow. What I would like to point out is that public health nurses have to adapt to an ever-changing environment that poses threats to our Manitoba residents. In this case, the COVID-19 pandemic. The changes have included the creation of the COVID team, but also changes to our general program. And on this slide, you can see that we had a complete halt to all our group programming, such as Healthy Baby, which is a group that promotes and supports healthy outcomes for moms, babies, and families, our breastfeeding group, and our nutrition groups. All meetings and groups stopped to abide by the social distancing and gathering enforcements. We suspended our school-based immunization program and redirected those individuals to their primary care provider for the interim. This redefined how public health nurses worked and how we could change our delivery services. For example, our STI follow-ups for chlamydia and gonorrhea halted as well, where we are only focusing on those less than 18 years of age or who are pregnant. So how did public health do things differently? Well, public health still followed provincial guidelines, contacting postpartum families by 48 hours, assessing the need for a home visit or an office visit. Out of COVID-19, we found that most families declined home visits due to the fear of having other individuals enter their home. So what public health did in turn was increase phone calls to families, more detailed phone calls actually, to be a little bit longer in length so that it would limit, if we do go out and do home visits, that it's less face-to-face contact. Some other options were dropping off a weight scale to the family's home, then retrieving it at a later date and doing follow-up phone calls to find out weights and see how the moms are doing. Following some of the new rules with COVID-19, there was a screening tool that had to be used before all home visits. Public health nurses are to use personal protective equipment on their visits or any contact with clients. They also assisted our COVID-19 team with case and contact with doorstop visits, like Mafari had indicated earlier in the presentation. They also helped and created online versions of resources for families. They also assisted interagency support by helping agencies deal with the COVID and the changes and social distancing rules. Some of the innovative initiatives that took place were our public health nurses were supporting the staff at screening area sites, such as the community offices. They helped with resources and helped with the screening. They also trialed with virtual Microsoft team meetings for one-to-one prenatal or postpartum visits. They're also piloting virtual groups for Healthy Baby and Healthy Start using GoToMeeting.com. Advertising was done on Facebook for initiatives to join virtual groups. Our Families First Home Visitor Program, which helps families learn about better parenting options. Our Families First Home Visitors would drop off packages with different activities for families, and then they would go back to the office and make a phone call to discuss what the activity they had dropped off. Mental health support by phone for families increased as isolation increased as well. We had to increase our outreach work, which also included more phone calls to families and just checking in for well-being to see how people were doing. We had Healthy Start, we had PHNs facilitating by phone, and there was also resume of We Matter Wellness Clinic, which was held at 601 Aikens for our vulnerable population who needed assistance with immunization. And they would be following the COVID social distancing practices. We hope that you enjoyed the presentation as it gave you a synopsis of how we are managing with COVID-19 in the Winnipeg Regional Health Authority. We are open for any questions.
Great, thank you very much. Okay, interesting presentation. I know I have a few questions of my own, but let's open up the question and answer bar here. For those of you who, again, just need a little refresher, you can pose your questions in the Q&A box, or you can click on the hand option, which also we can unmute your mic, and then you can voice your question to the presenters if you like. Okay, so the first question, what type of PPE was specifically worn during home visits?
What was used was a face shield or goggles, face mask, and they would also have gloves and gown for use.
Okay. Great. And then there's a question here that says how. I'm not sure if that was added on or, so if you'd like to expand on that question, you can go ahead and type another one if you like. Oh, there we go. How, it's coming through. How is the management of public health services differed throughout the provincial regions?
I think they're pretty much the same as ours in the Winnipeg Regional Health Authority, I would think. Each region might do things a little bit differently, but I would presume that they're also doing their cases in the Interlake and different regions. So we're all kind of focused on the same case forms and the same intern guidelines we're using. But I would assume that they're doing kind of the same thing that we're doing.
Okay. So there's not like a regular type of a communication with all of the different regions? Really?
So this is Tanya here, one of the communicable disease coordinators here in the Winnipeg region. So provincially, there are tables higher up than even myself, where medical officers of health convene. And so those were regular meetings that occurred for decisions to be made so that there is some consistency across each region. And the public health, the interim measures public health document guides all of our practice across the province.
Okay, thank you. Did I see here that, Mary, did someone say we had anyone from the association that could comment on that as well? Did I see that in the question box and answer?
I didn't see that question.
Okay, I just thought I saw an answer.
Okay, I could certainly echo what Tanya was saying from my experience that usually the directors of public health and the MOHs for the various regions very much work collaboratively so that there is that consistent approach across the province using the same tools as Sylvia was mentioning as well. But there, depending on the population being served, that's where there may be some diversity or some differences as well.
Mm-hmm. Okay, thank you. Here's another question. Are you aware of an increase in domestic violence incidents during the pandemic?
I am not aware of that at this time.
Okay. I see that we have a response here in the question and answer that says, I spoke with a female police officer today at morning outdoor boot camp, and she said that domestic violence calls and mental health calls are way up and that break and enter calls are down. So I can speak to the mental health perspective, at least in our region. We initially, the mental health, people presenting to the ER for mental health concerns had been pretty low, but over the last probably 2 or 3 weeks, our ER has started to increase in the number of people that are presenting with mental health issues to the ER. And I also know that in community mental health, I'm in the Southern Health region, that they're beginning to have some increase in numbers too. Mm-hmm. And I don't know anything specifically about domestic violence, but yeah, definitely substance abuse issues. We're seeing a lot of that in our ER. Mm-hmm.
And if I can add, Melanie, there is a resource that Manitoba government has been promoting about every home should be safe type of thing. So if anybody is experiencing anything like that, there is now a very special resource that's dedicated to that on the website, on Manitoba and the Shared Health website.
Oh, great. Thank you for sharing that. Mm-hmm. Okay. This is with regards to the screening tool. So is this the tool that Health Links uses?
Again, it's Tanya here, one of the CD coordinators.
So yes, that screening tool is utilized by both public health as well as health links.
Okay. Do you have opinions regarding the current criticisms of the WHO and its management and information provisions globally?
I think that it's Bari, and I think that I've seen the criticisms, and I feel that although it's the first time that in our lifetime that we've seen a pandemic, so I feel like maybe with what they've been doing, they've done the best they can with the information they had. That's just my feeling. I'm not sure whether, like, I can't really say how I feel about the criticism or not, but I feel like it's the first, like we're all doing this for the first time, and I think that we are doing the best we can with what we've had.
Right. Mm-hmm.
Hi, it's Mary here. I agree with what you're saying, Mari, and I think it's unfortunate that there's been so much in the press right now, stemming from some of the criticism coming from our country to our south. And it's so interesting because it's such a complex issue, and we get shared many of the International Council of Nurses work that they're doing with the WHO. And I, from my perspective with the association, I've been so impressed with the degree of evidence that they are providing and the cautions and things like that. So it's really quite interesting. And I don't, as you say, it's such a novel experience that we're going through across the world that, how would anybody know how to do it right? And I just think that personally, and professionally, I've been very, very impressed with the work that WHO has done. And I hope that doesn't get undermined from some of the I shouldn't say minor, but some of the criticism that are happening.
And they are opening up an investigation into their own practice. I think I read that as well, that they're open to going back and really evaluating and analyzing their own sort of process, I think, at the beginning and all throughout. So I think that's very positive as well. I
think that the World Health Organization has done the best they can with what they've been given, but I also think that they're also being proactive by having that investigation, or they've talked about having that investigation. I think that perhaps other places will also look at investigating or having kind of a debriefing, shall we say, when this is over, to see where we may, or maybe Canada could have done something different. I mean, hindsight is 2020, and I just find it interesting that people are so quick to criticize when we're still going through the pandemic. It's not over, and they're still quick to criticize. So that just doesn't sit well with me.
Mm-hmm. Yes, I agree with you, certainly. Okay. Do you have enough PPE, and how or where do you dispose of it, store it after your home visits?
Well, each nurse will take a garbage bag with them. So when they are done with the visit or home visit, they will then remove everything according to the way that they were taught and put into a garbage bag and then disposed at work in our garbage bin, just our regular garbage.
Okay. So no concerns for running out of PPE, not enough PPE. It seems to be that everyone has enough.
We've been reassured that in public health that we have sufficient PPE available to us.
Great.
Keeping in mind that we're not doing the same volume of home visits that we would do if we weren't in a pandemic. So we aren't still seeing the same volume that we were prior to this.
Right, so you're prioritizing people and families and cases that you need to absolutely see, and the rest you're doing by virtual or phone.
Exactly.
Okay. With the recovered cases of COVID-19, are we using any antibody tests to clear people?
We're not using. There isn't anything formal with recovered cases having testing done, but the University of Manitoba, I believe that study is still in process. They were, I don't know if soliciting is the right word, but they were inviting cases to consider being a part of their study for testing to be done. But otherwise, there isn't anything formal being done. As part of the education that we did when we were doing our phone calls, we included the U of M, the University of Manitoba study, so that the clients could make their own decision whether they wanted to participate or not. And that's how we helped the University of Manitoba.
Okay, great. Are you concerned about asymptomatic carriers?
Yes. Yes. I think we're learning. We're going day by day. And yes, we've had some cases that have said they've had no symptoms. So we are looking into that. And I think that's where our FBE stats come in, and that we're keeping a very close eye on those. And we haven't seen, we're going to be testing more and more people. So hopefully we'll start to see some of that information coming forward to help us with our case studies from here on.
So I have a question that's a little bit linked to that, but just this idea of like COVID being in Canada before COVID was in Canada, right? And so people are talking about like having really suspicious kind of weird types of COVID symptoms back in December and then early January when we really didn't know or think that we had any symptoms here at all. What are your thoughts on that?
I definitely question that as well. I think it's on our minds. So it'd be interesting if they do the antibody testings, if people can come forward, can maybe assess to see if they have had it. I think it's definitely something worth looking into.
Yeah, I agree.
So just considering there are some unknowns with, at what point antibodies wane. So certainly if somebody was ill with a pneumonia type presentation in December, who's to say that they may have had COVID post-travel.
Mm-hmm.
Dr. Carol Kurbis is in the process of revamping or giving our interim public health measures document a bit of an overhaul. And so I learned today from our medical officer of health, Dr. Wunmi Fatoy, that maybe a little bit on the down low, but certainly when public health nurses are doing, or the COVID team is doing their case investigations, if contacts, if it's been at least 5 days since their last exposure to a case, and they are still asymptomatic, that we are in a position to have them be tested. So we might end up picking up some asymptomatic contacts that way.
Okay, so you mean even say now, if there had been a person that was in contact with but not symptomatic, they could now be tested, or they have been tested post?
Assuming that 5 days have passed since their last exposure to that case. So these would be identified contacts to a positive case that may not have symptoms yet, but at least 5 days have passed since their last exposure to the case, that testing would be done on those individuals.
Okay.
Because that was one of my questions, Tanya, was how do we know that someone is an asymptomatic carrier? Like, what prompted them to get tested? Like, prior to, like, is it only if they've been in that contact tracing loop, so to speak? Because I just wonder what criteria or what precipitated the testing of that particular individual who wasn't showing symptoms, or has there been much of that yet?
I don't think there's been much of that because we had very strict criteria to begin with. And then as things have progressed, we've kind of loosened up some of those testing requirements. It was very, very strict before. Like you had to have symptoms, you had to have a high fever, shortness of breath, cough. If you didn't have any of those, then, some of our cases, unfortunately, their contacts would often fib to get tested. And then that's how sometimes we were able to pick up if it was asymptomatic, because then it would come out later in our conversation that they actually weren't symptomatic. But again, we had strict protocol before, and then it was just some people who fibbed when they went to get tested and got tested.
Oh, okay. That makes sense then. Yeah. Because I just wondered, well, how would we even know? Right.
Yes. I do remember a couple of outliers. One individual was identified because there had been cases involved in some travel. And so this individual was identified as a contact. And I think, like Sylvia mentioned, there was a little bit of fibbing, and so presented to the to urgent care or to the ER, and then was tested. And at that time, we were rather surprised when they tested positive. We had another individual whereby a family member was already recovered, a positive case who had recovered, but the hospital had decided to test the household contact, even though they were asymptomatic, because they were immunocompromised. And then we were also surprised that that individual tested positive.
Has there been much false positives? Has there been any incidents of that? Like, I guess, how would they know though? Like, yeah.
I would say about a handful.
Okay.
Kind of throughout since this started.
They tested presumptive, and then either further testing was done by Chatham Provincial Lab, or our medical officer of health requested that the individual be retested, and then they were ruled out as not a case. But we would collectively say that less than a handful.
Mm-hmm. Thank you for that. That's very interesting. Okay, was SARS not considered a pandemic? I think it was a pandemic, right? Or was it not?
I don't think.
I don't think. I mean, I could be wrong, but I don't believe it was considered a pandemic. And I think that the reason was, while it was more, the outcome of SARS was, the mortality was worse with SARS, but the communicability and the infectiousness of SARS was not as bad, to the same scale as COVID. And I think that might be part of the definition. That might be, I could be wrong though. Don't quote me, but I believe that might be the reason.
Okay.
Same with H1N1 as well.
Okay. So I just got a comment here from Laurel, who's saying that that the WHO does classify SARS as a pandemic.
Oh, okay. Thank you.
Yeah. Okay. Harm reduction distribution kits have decreased provincially. I'm not sure if that's a question or a comment. Adele, want to add to that, just so that maybe you've added. Oh, okay. She says, sorry about that. Okay, so is there planning for immunization clinics like we're done for H1N1? How do you see the rollout of a vaccine once it's available?
I think it would be very similar to H1N1. I think that if the vaccine is available, then we would be doing mass clinics throughout the province.
As part of public health, that would be our mandate, would be to immunize as soon as we were able to safely. And I think that the way we dealt with H1N1, at least in our careers, was as soon as it was available, we did, I believe it was a week, if not two, of community clinics across the city, very similar to the way we used to do our influenza clinics. And it was a priority, and it was all hands on deck to get those clinics done. And I think that that's exactly what would happen once there's a vaccine for coronavirus. I feel that it would be across Canada done the same way.
Mm-hmm.
Of course, we'd have to keep in mind social distancing, which will push us to really creatively think about how we're going to deliver our immunization program moving forward, and that includes our school-based clinics as well. I don't think any ideas are off the table. We're even discussing, and don't quote me, I don't know how things will evolve for us as time goes on, but in Australia, they're actually conducting mobile or drive-through immunization clinics. So yeah, there's a lot to think about, and a lot of planning as we move forward. We are anticipating a second wave, which will likely be married up with flu season. But we also have our school immunization program that we need to plan for as well, considering that we halted that when COVID was at its peak here in the province.
Mm-hmm. I have a question about the second wave in Manitoba. So if our cases get down to 0, or in the between 0 and 10, or 1 and 10, what is the probability of us having a second wave? Is it dependent on the borders being open? Like how do those decisions get made? And would that constitute a second wave, or is it the asymptomatic people that will infect others?
I think that's the million-dollar question. I don't know if we have an exact answer. I definitely, there's speculation. Dr. Rusin had mentioned that once we started to lax some of our rules and phases, that there may be a spike or increase. So, I mean, if we can all still remain, stay home, that's the message. Wash your hands, social distancing. Maybe we can still control it and be on top of it. But I guess where we worry is if people start to lax a little too much. Just this past weekend, going to parks, you see more than 10 people kind of hanging out. We have our inspectors going out and about and reminding people. But I think as we see those lax, then we'll probably start to see some increase in cases. And again, when you start opening up borders, well, possibly, I guess it changes as well. But I think that's a $1 million question.
So if we were to see no cases in a 14-day period.
Well, I wish, I don't profess to be an epidemiologist, but thankfully in the Winnipeg region, we do have an epi team. So I wish she were here to speak to this. But typically to call something over, like an outbreak, to call it over, it's 2 incubation periods. So if 14 days is our time frame, then double that. So it's nearly a month.
Wow.
We just were informed of a new case here over the long weekend. So I'm not sure what our epi team would say, depending on how potential cases where they're asymptomatic or not trickle in over the course of the next few weeks.
Yeah. Okay, thank you. All right, back to the question and answer board. So when immunizations are being given, is there any concern about anaphylaxis and the need to provide CPR? Are there any special precautions that need to be put in place?
Absolutely. We had that with H1N1 where we had some increased cases and we need to use the anaphylactic kit. We have them available at all our clinics. We're all trained. And
I think, don't quote me on this, but I think Manitoba Health is also relooking at their anaphylaxis protocol. because we've also received feedback from, say, our trainers, like St. John's Ambulance, that in a situation like this, chest compressions are the key versus breaths. So during COVID, I think the province was looking at possibly revising the protocol, which would support us in our efforts during an anaphylactic event.
Mm-hmm.
And we probably would be doing it like at community centers or larger venues where they may already have AED available as well. Right. So we would have those to access as well.
Okay, great. Mm-hmm. Are you aware of any province initiatives or plans for those who will be impacted by economic fallout from the pandemic, and how this will impact the overall health of the community?
I don't think I have the answer to that.
Mm-hmm.
But definitely be a good question for Alistair maybe, and one of our members of parliament perhaps would have a better answer to that, and what the fallout will be and where the money will come from. But we hope, I mean, it sounds like good news that things have been happening, but I can't, what extent, and I don't think we can really comment to that.
Right.
I can just add that there's currently on the Manitoba government website a variety of programs. So I'm not sure the person who was asking questions related, whether it was related to other organizations like small businesses and things like that, but there is quite a few initiatives that have been driven, starting from the feds, where they provide funds to the provinces, and if the province matches them. So there's a variety of things that are posted on the government website. For example, the association as a not-for-profit, there's opportunities there to, if we had a loss of income or things like that. So there's things that way. But again, there's lots of complexities across the board, but there's certainly programs like even for summer students that aren't going to be able to have the same amount of income because of the lack of jobs. They can apply for funding. So there's quite a bit of work being done, both collaboratively, which is great, between the federal and provincial governments.
I know from a mental health perspective that it's definitely something that psychiatric nurses and mental health professionals are worried about, because work is an important piece to a person in recovery from mental illness. Any kind of work that they're doing, volunteering, and your job provides you with meaning and purpose. And so that can really, really have an impact on community mental health from that perspective. Mm-hmm.
We have a great resource too, the Helping Neighbor. That's what they ask. So we've offered that resource to many of the cases in case they needed assistance with getting groceries or just assistance out in the community. So I mean, there's great resources out there. Just a matter of, I guess, looking around to see what's available.
Mm-hmm. Okay, what specific steps have been taken to assist homeless population in Manitoba? What percentage of homeless population has approximately been tested?
Well, today's announcement that they opened Thunderbird House as a testing site, which would hit some of that population, was welcome news. We've been waiting for that to open, so we're really pleased about that. We have heard, and maybe Sylvia, not sure about the shelters. That like there have been places that have opened to our homeless. I can only speak for what we know is happening in Winnipeg, but I feel that probably other larger centers would also be able to have that. But it's been amazing what the community has been able to do to facilitate if there is any situations in the homeless population that we have been able to accommodate, or we would be able to accommodate them for isolating. I think it needs to be projects.
Yeah, I would think it needs to be projects. difficult. We don't have an exact number right now, but I guess presuming today as it opens up that we'll hopefully start to see more people being tested absolutely from that population.
Mm-hmm. Okay, great question. This is kind of a comment. I thought only people that were having symptoms were getting tested.
So they broadened that up quite a bit. And yeah, so the slide that was up that, and I can't recall off the top of my head, maybe you can, Tanya, but the first part indicated one of the following, and it included anything from fever, diarrhea, vomiting, shortness of breath, and then or two of the following, and then there were minor symptoms, runny nose. They're just bringing it up so we can kind of read it off. But I think that if people have been showing up for testing, I don't think that they're refusing those people away. They're coming for a reason, but I think they are testing. So the screening, we were referring to the screening tool, is that correct?
I think so. It wasn't specified.
Okay, yeah, so yeah, just to review here on the screening tool. So it says, do you have new onset of any of the below symptoms? So one of the following: fever, cough, sore throat, hoarse voice, shortness of breath, loss of taste or smell, vomiting or diarrhea for more than 24 hours, or poor feeding in an infant. Or do you have any onset of two or more of the following symptoms: runny nose, muscle aches, fatigue, conjunctivitis, headache, skin rash of unknown cause, nausea, or loss of appetite? So we broadened it quite a bit, so a lot more people will test it. And like I said, I think that if people are showing up with concerns, I don't think that they are turning them away, but I can't speak to that.
Okay, so our participant here added on to her question and said no more. So it was about the conversation about people lying to get tested.
Oh, like she wanted to know how many, or?
Some regions may be more stringent on the criteria than others.
I think each testing site would be depending, but also it depends on how, I don't want to say harass, but some individuals would be constantly saying no, persistent. That you need to test me. I need to, if you turn me away, I'm going to sue you. So there were things being said out there in the community. I mean, even in our conversations with some of our cases, we had anywhere for the lovely elderly person speaking to us to a cranky person. Like we had such a variation of people's personalities, which was very interesting to see and to deal with. So I can only imagine when you go to a testing site how it would be very difficult to sometimes turn away people.
What's your perspective on our numbers of people tested compared to other provinces? I
think we're doing pretty good.
Okay.
I think the Manitoba stat from today's stats was 2.1, and the Canadian average was 2.8%. So we're pretty good. I mean, yeah, there's always room for improvement, but I think we are doing better. At the start, I know we had some glitches and it was getting really hard to get things going, but different factors were playing and different partners were playing. We were all trying to work together and try to get everybody organized. So there is going to be some glitches at the beginning like we did.
Yeah. Okay, well, that's great news. It's good to know. All right. Are you aware of Shared Health has any planning in place for follow-up of future anticipated rise in other CDs, STIs, mental health demise currently not being followed as was prior to COVID?
So we represent the general program. So unfortunately, I can't speak to the healthy sexuality and harm reduction team. My understanding is, for example, that tuberculosis, their program is relatively stable at the moment. My understanding, the last I spoke with the MOH for that program. Certainly with social distancing, the restrictions that have been put in place, some of our other general CDs have decreased in volume. And then at other times, there's been kind of waves, like it's ebbed and flowed, the general CDs. I think those conversations are always on the table, and we discuss them routinely, at least the ones that impact the general public health nursing program. And so those general CDs are all the reportable communicable diseases, except for, including hepatitis B. but excluding TB and sexually transmitted bloodborne infections, the other ones. And as you heard earlier from Sylvia and Bari, that chlamydia and gonorrhea has been absorbed by the general program. So I think those infections are always up for discussion, and that we are just trying to adapt as the lab reports come in.
Okay.
I don't know if that completely answers the question.
So we're just some comments from when we were talking about the testing. So it just may cause some bias in our results from region to region. And then another one, I thought most people used health links to get approved for a swab. But I think, as you were saying, some people, if they were presenting at a site and demanding to be tested because of symptoms, would testing go forward?
That's changed though. So you do not have to phone health links now. So that's open, officially is open. You do not need to phone health links in order to get tested. You can just show up to a site and with the following symptoms that we had listed off.
At the end of the day, those testing sites or assessment sites, that clinician ends up doing an assessment, right? And then deeming whether you meet the eligibility criteria and whether they're going to test you. We've had the occasional individuals, I think, reach out to their community area offices, maybe a bit frustrated that they weren't tested. But that is likely a result of them not meeting the criteria at the time that they presented. But like Sylvia said, officially now we've received word that, here over the weekend, that now people can freely present and then be assessed on a case-by-case basis and do not need to wait for health links to approve for them to go for testing.
And I think earlier too, we would have the opposite happen as well, because we would refer people to go to the testing sites and they would be turned away because they said, well, public health sent us. So it was all communication. We had, it's hard to communicate with different sites, but we were just learning as we were going. So it was funny that we had the opposite happen too, because we would be referring people to go get tested because they had symptoms, and then they were turned away because they said they didn't go through health links. But I think we're learning as our processes are going forward.
Yeah. Okay, and just a comment here. The WHO recommends to test, and test some more. So quite a few of super spreaders around the world were completely asymptomatic.
Definitely. I think that's what Dr. Roussin would like as well. I think it's across Canada, Dr. Khan as well. I think that they all want to have increased testing. So I think that's what we've been doing a good job, and it's open. This places are open for people to go get tested, and we've opened up parameters. So I'm hoping that we're going to continue to see good numbers.
Yes, agreed. Comment here about mental health. Have you noticed an increase in self-harm or suicide attempts?
I don't think I can speak to that, just because we've been dealing with our cases and contacts, specifically with the COVID team. I'm not sure, Melanie, if you have a perspective on that, or if you can speak to that.
So what we're seeing is people are trying to cope using substances. And it's when the overuse of substances that really disinhibits and then brings up the more and more thoughts of suicide if they weren't already there before. And then it can potentially pose a risk for people to act on them. So we have seen that is starting to present in our ERs, I think. I'm not sure about the Winnipeg Health Region, but certainly saw cases on the weekend in our ER, where people are really just struggling to cope, and and they're using substances to cope, and then,
And specifically to postpartum, I know the general program had commented to us that they were doing more supports by phone, just, because people were isolated, and of course postpartum depression. So I know that there were more phone conversations happening just to support families and checking in on them. But I don't know if I can, if there's stats out there that can say, there's definitely an increase, but definitely just by word of mouth, that's kind of what I've been hearing as well.
One of our big concerns was that people weren't accessing the ERs anymore for suicidality. And so I think the message is starting to come out more and more that, just please don't, ignore your mental health, that you also need to attend to the ER if you're struggling, or contacting one of the crisis lines that are available across the province.
It would be interesting to know how, like clinics, crisis line, or the crisis response unit here in Winnipeg, kind of what they've been observing.
Yes, that might be another topic for one of our Talk Tuesdays. It's a good idea. Okay. Well, it looks as though we are finished with our questions. So I just, I thank you to everyone who remained on the line with us. We're a little bit after 9 o'clock, but certainly a great discussion that we've had. So I just, I thank you all, and I hope that you all have a good week ahead of you, and we'll see you next week.
So I mentioned about the evaluation, which is great. So again, thank you for joining us tonight. I hope that you keep coming to our Talk Tuesdays. Next week, we're going to have Victoria Merrick from the Manitoba Gerontological Association. So where she's going to share the challenges and opportunities and experiences that they've been having in the long-term care sector. Because we recognize the nurses work across a variety of roles and settings, and these Talk Tuesdays provide a really great opportunity for us to, as colleagues, share and listen to the experiences of others. So thank you so much for that. And as well, please visit our COVID-19 page on our website. It's regularly being updated with not only local website information from Shared Health and Manitoba government, but we have it at the national level as well as international level with the work that we do with the International Council of Nursing. So please visit that often. So again, we appreciate you coming tonight. We thank you for all you are doing out there, not only from our presenters, but to each one of you out there in the nursing world. So thank you, everyone. Take care and good night. I will end the webinar now.